Good afternoon, everybody. Welcome to the March All You Serve webinar. We're going to give another minute or so for people to get on, and then we'll get started with our wonderful program this afternoon. So give us about a minute, and we will move forward with it. All right. All right. We will now get started. Welcome to March's All You Serve webinar series. This month, we are very lucky. We are going to have Della Dunbar speak to us about demystifying the room service implementation. Before you get started, my name is Marcia Diamond. I'm the new business development for All You Serve, and All You Serve is the sponsor of this series. We're very grateful that All You Serve has allowed us to bring these educational programs to every one of our partners out there, operators, members, etc. So welcome to Demystifying the Room Service Implementation. And today we will explore the key components to a successful room service implementation and show how room service is an option for every hospital. We have with us, we're honored to have with us, Della Dunbar, MSRD LVN. She has been at Hotel Food and Nutrition Management for over 25 years. She's been with DM&A for about 7, and her role today includes nutrition informatics coach and room service project manager. Her education, she has a Bachelor of Science from Nutrition and Dietetics from Loma Lima University and a Master's in Institutional Management from Kansas State University. DM&A averages about 10 room service go-lives per year, and she has done over 200 room service implementations with them. So the 3 takeaways today is the true definition of room service, why your facility should implement room service, and keys to a successful room service operation. And Della is going to give us her expertise and her experience and share it with us from her over 25 years plus. Thank you, Della, and welcome.
Thank you, Marcia, and I'm glad to be given the opportunity to present this webinar today. To start, I think the first thing that we need to do is actually define what room service is. What room service is. There's lots of different definitions out there. We hear lots of things, people saying they have a hybrid of room service. And at DM&A, the way we define room service is that it is what the patient can order what they want when they want it. We want to give that control to the patient. It's very important. They have very little control when they're in the hospital, choosing what they want to eat, and more importantly, when they want to eat it. People have tests. They may wake up not feel well, but at 10 o'clock want something to eat. And in a room service environment, we can provide that to them versus, well, we got, some applesauce and crackers, on the unit, and you have to wait till 11 o'clock for your lunch. If somebody's wanting to eat dinner at home later in the evening, and they eat dinner closer to 6:30 or 7 o'clock, maybe they're ordering their meal at that point in time with room service versus your unit gets fed at 5, and that's not when I eat. What room service is not is getting patient selections at the bedside with a tablet, but meals served at set times. So there's a lot of facilities doing spoken menu, and somehow that's a hybrid of room service. Patients are getting to select, but they're not choosing the time they're receiving their meals. There are a lot of facilities and hospitals providing a restaurant-style menu, which looks very much like a room service menu, but again, they're getting their meals at set times. I've been in some facilities where the patients have a menu in their room, but unless you call by a certain point in time to a call center and change, tell them you want something different, the menu lists what today's chef select is or the non-select menu, and if I don't call, I get that, but if I call, then I can choose. So those are things that are not room service. The way room service works in this type of environment where patients are calling and ordering what they want when they want it is it starts with the patient. They talk to someone in a call center. The order's entered into software. There's typically 3 printers on the line, and a ticket prints appropriately. The tray gets prepared and is placed in a cart, and we want that tray off the line and in the cart within 15 minutes and delivered to the room in less than 45 minutes, and we're exceeding our patients' expectations when all of that comes together. Who has
And I was
on
going to
demand?
say,
Oh,
Della, if I may, if you have any questions as we go along, please type them in the question field and we'll get to them towards the end of the program. Thank you.
who has on-demand room service? Food Service Director magazine did some research, and this was published in May in their magazine. And it's showing that at this point in time, the Midwest has really adapted and has the highest percent of facilities that are actually doing room service. And in the survey, they found that the larger the hospital, the more likely it is that they will actually offer room service. So what are some of the reasons why I should implement room service? One, and we hear about, and even though DM&A does do an ROI, and there is reduction in waste in the system, that's not really shouldn't be our primary focus for why we do room service. First and foremost should be we want to improve our patient satisfaction and provide the service, improve the service and quality for our patients. In today's world, CMS is doing some of their reimbursement based on the hospital's total performance score, and that's linked to patient satisfaction. On HCAHPS, there is a section of questions related to the patient and caregiver-centered experience and coordination. That's 25% of this total performance score. Even though food service doesn't have a specific question, room service can contribute to the overall hospital score for that patient-centered experience and showing coordination between the caregivers within the hospital. We know from our clients who are doing Press Ganey or some other type of survey that if hotel-style room service is executed well, they will reach the 90th percentile in patient satisfaction. Our hybrids and some of these other types of systems do not give the same result. We do reduce food costs, and how do we do that? Patients are ordering just what they want. Typically, we're sending up a tray with lots of, we have to send a starch, a vegetable, an entree, a beverage or two. We send a salad, we send soup, we send bread, we send a dessert or a fruit. And patients don't really eat that much food, so when they call the order, they may order the chicken breast with the mashed potatoes, get a beverage and a piece of fruit. So we're not sending up food that's not consumed. We take late trays out of the equation, and because patients are eating their food, we're not needing to provide the snacks and supplementation that we might otherwise provide. There is a reduction in incidence of malnutrition, and that goes back to when I get to order what I want, I'm eating that food, and then if I'm hungry a little bit later, I can call for a snack, and then I am eating better, therefore I'm not malnourished. Okay, my slide's not advancing.
Oh, not advancing?
No, was. Okay, thank you.
Okay.
So another part of room service can help us contribute to meaningful use. This is a term that you may have heard in your organization, and the government through Obamacare is dictating what's happening on the electronic healthcare side of the business and having functionality and everybody talking to each other. And one way where room service helps contribute is one of the requirements is that it's documented when patients need education for their diet. And when we're in a room service call center environment, I think we have an opportunity to provide more patient education on their diet than we ever have. And being a dietitian, I've seen this. When a patient calls and they're on a heart healthy or cardiac diet, we see that information in the call center as they're ordering. We're tracking the amount of fat and sodium in the foods that they are ordering, and we see if they've gone over what we can allow for that meal, or they've gone over what they can allow for that day. We're counting their carbs, and then in our scripting, we're asking the patient to modify their order. You have 5 carbs. I need you to choose between the milk, the juice, and the fruit, which you don't want this meal. Or, you have bacon for breakfast today. You're over in the sodium and fat. How about having potatoes as another option, or offering, maybe I have a turkey sausage that's healthier for them. I've actually had patients tell me when we implement room service and are going through the scripting that they have found it very helpful in helping them understand how to make the right choices when they go home. And that's nothing we've ever been able to do at the bedside with a patient, is ingraining in them and helping them understand their diet when we hand them a piece of paper. So Marcia, I think I've lost the keyboard. Can you advance? Okay, thanks. Hospital size, all size hospitals can implement room service. We've had implementations in facilities as small as 10 beds up to 1,200 beds. They all have issues and their own challenges. Of course, the larger facilities, coordinating, we may have 2 lines running instead of 1 line. We most likely are going to have a psychiatric population, a rehab population, maybe a long-term care population that we also have to feed. In addition to the acute inpatient, smaller facilities, we pretty much, everybody has to know all the tasks. So, anybody may need to take an order. Everybody might have one person working on the line. So even though, it seems like maybe smaller is simpler, they all come with their own challenges, but everybody can successfully do that. So next. The keys to success, there are many keys to success when you're implementing your room service, and I will talk about each of these different steps. There's a lot of planning that has to be done, a lot of little details that have to be done, and as we talk about each of the steps, we're going to see the things that we have to consider when we're doing this planning. When we're building our menu, it needs to answer to all of our diets. Marcia, can you advance? Okay, there. Needs to answer to all of the diets. We need to have sufficient number of offerings that patients can find something to eat. The menu needs to be executed well, but we have found that just good basic food done well will get us our satisfaction scores. We don't need to be serving fancy foods, and people are sick. They want some just simple, basic home cooking. We don't need that 5-star type of meal on the plate. And when we look at our basic menu, we see that, with breakfast being served all day long, we have 50+ entree choices at any given meal. So with an average length of stay of 4 days or less, people are finding what they like to eat. We've also found at Go Live, patients may order French toast for breakfast, thinks it's really good, and I've had people call because they liked it so much they order the same thing the rest of the day. They get it for lunch or dinner also. Other keys to the successful menu is we need to think about the print size, the readability. I'm on the next slide. Choosing items that can be served to everyone. So maybe in our yogurt offerings, rather than have 6 types of yogurt, we're doing a smooth yogurt, a light yogurt, and it's served to everybody. We have high quality, lower sodium broths and soups. We want our entrees to be more moderate in fat and sodium so they can go to everybody. When we talk about our soups and our broths, a lot of patients are in for surgery, and really the only diet or meal they get to see are clear liquids. So we like to make sure we have really high quality broth, because when those surveys go to them home, they may not have actually eaten a regular meal from us that might have been the clear liquids was all they got. We want to start with a basic menu. Your staff has to learn how to cook to order. We're going to avoid a lot of build your owns, an omelet to order, or a pizza order will have omelets and pizza on the menu, but we offer 3 kinds. Soup of the day, fruit of the day, those things are very hard, and entree specials of the day are hard to manage at the beginning. We need our speed of production related to our ability to create those items. A myth that's out there is that, and we've in some facilities when we've gone in and they've asked us to come help do a tune-up, where they've printed and have a menu wall of room service menu. This is expensive to maintain. We think it's better to have one menu. We use heart symbols, put carb counts on the menu to help the patients make their choices. And then we can guide them through gluten-free options. We have some facilities that have a gluten-free patient. They have a handout that they give them with the gluten-free options in addition to some of the other standard items that may already be gluten-free on their menu. Pediatric menu doesn't have to be very different. We've had clients who have a pediatric population. They take the same room service menu and just print it on paper that's more kid-friendly, but the food items are staying the same. I have some sample menus in here. There's one that's a regular menu, as well as we can show what a pediatric, taking that same menu, putting it on paper that's more kid-friendly. All patients select from room service menu. Again, when you're doing room service, you want that to cover 90% of the population. Room service isn't perfect for all of our patients. It doesn't meet all of their needs. We may have patients who are unable to participate due to their illness. They can't talk to us, let us know what their preferences are in food. We like to categorize our patients into 2 categories. Our preference always is that you want your patients to make selection. So if someone's unable to use the phone, I might need an interpreter to work with them to make their menu selections. We have a category called room service with assistance, and we're finding that 10 to 15% of the population falls in this group. We'll take a tablet, we'll go visit them, we ask them what they want to eat, and then when they would like their meal. So even though they're making choice and selecting their food and the time they're going to eat, they're not picking up the phone and calling us on demand. Those selections are taken ahead of time. We also find that there are sometimes what we call our non-select chef select patients, and these are patients who aren't able to communicate at all with us for various reasons, and there's not a family who can order, member who can order for them.
Della,
Yep.
I don't know if we're having a bad connection, but if you can speak a little bit louder and slower.
Okay.
I think people are here. Okay. That would be fabulous. Thank you.
Okay, so with chef select patients, these are patients who cannot articulate to us what they want to eat, and they do not have family who can articulate those or call for them, and these may be post-stroke patients, demented patients, so they're on what we call a non-select. We've created a 7-day menu cycle based on our room service menu, and this really needs to be less than 10% of our population and not a high number. So there are clients where we find we go in and they are actually have a high percent of patients in this non-select model, and that is very difficult on a room service line because we're now getting batches of tickets and trying to feed batches of patients that have been misclassified as not being eligible for room service, and that slows down our room service line. Marcia, can you advance? Thank you. We're finding a lot of. Yep.
Okay.
We're on the right slide now.
Okay, we're on the right side. People are asking for a little bit more examples, some of the questions that came up, so just FYI, I'm just going to throw it out there as we're speaking. Thank you.
So with a behavioral rehab type unit, We're finding hospitals have this, so we're needing to come up with a plan to feed these patients because they want meals, coordinated times in a rehab unit. They have therapies, and everyone eats in the dining room. We still make these trays on the line, but we need to come up with a way to get their selections. Some patients, as part of therapy, are actually calling the call center, but we still batch the tickets together. There may be a paper menu, or again using the tablet for a spoken menu, and I do have a slide that shows what this paper menu looks like. Some places allow behavioral health to make selections, other places have them on their non-select menu, and we can use the same paper menu in that environment. I'm finding as we're doing implementations that a lot of hospitals, a big piece of their business, because the community is not providing for behavioral psychiatric care, that hospitals have units now with those types of patients, so we're having to consider them when we build this room service line. This is an example of a menu using the items that are on our room service menu, and that patients can choose from. We basically take the menu offerings that we had on room service, and the entrees are split between lunch and dinner. So a lot more variety than potentially a paper menu today, where there's 2 entree choices at a meal. In the psychiatric population, they may want a hamburger every day for lunch, and they're able to do that. So that does give them a little more choice, but we're still not allowing them to have the room service options. Another myth that is out there, I don't know, sometimes I'm advancing Martian, sometimes I'm not. So, oops, go back one, couple, I guess.
Dilla?
Yep, I'm on the myth for liberalized diet. I don't know why it.
You want to get in that one? I think you went too far. Let's get you.
Maybe I just have a really slow connection. Sorry, everyone, for these technical.
Where are you wanting to go? Right here?
Right here. Yep, I'm.
Okay. Okay.
So when we hear the term liberalized diet, which it is a term that gets used with room service. A lot of people interpret this as being a patient can order any food item they want regardless of their diet. The way we present it, and when we do a room service implementation, is we want our recipes modified healthy for everyone, and we want the patient to order what they want within their diet prescription. What this means is my software I'm using to take the order is allowing me to count how much sodium, how much fat this patient is ordering, how many carbs they are ordering at their meal. And so we're allowing them, if I don't want very much to eat and all I want for breakfast is an egg and a couple pieces of bacon, I can have that on my heart healthy diet because I'm within my sodium limit for that meal and for that day. Same with carbohydrate counting. If the patient doesn't want to eat very much, but they have a brownie which counts as 2 carbs, and they want that and they're within that carb count for that meal, then we let them have it. So our software system guides us through that. We have scripting. I'm sorry, Mrs. Smith, the items you've chosen for your meal put you over your limit with regards to carbohydrate or sodium, may I suggest, and then we offer alternate items and suggestions for that patient when they're making that choice. So that is how we interpret a more liberal approach. And I know there are times that we do have pushback from nursing and physicians in regards to letting them do that. And we need to educate that we're allowing these patients to be within their diet that has been ordered if it's a 2-gram sodium, and we can show to them that the patients are eating within that. Another myth that we see out there, and people want their diabetic patients to eat at a set time again, so we're not letting them order their meals when they want them. There is a coordination that has to happen between the giving of the insulin and the tray delivery. So we implement a process where we're seeing the patients who are on insulin from our medical record. We notify nursing when the patient orders their meal. Our scripting often is to have the patient press their call light to let the nurse know they ordered. We check with nursing prior to delivery of our tray to make sure it's okay to deliver that tray. And what we're finding this works well, patients actually stay on the schedule they follow at home for their medication, and there are fewer blood sugar issues because medication is given when the meal is delivered. In one of our facilities, we were meeting with nursing and the diabetic educator, and the diabetic educator was a big believer in room service, and she felt within this organization they had a lot of low blood sugar issues because the unit was expecting trays to arrive at a certain time, and they would go around, take their finger sticks, give their insulin, and if the trays were delayed, now I had patients who had another issue because their blood sugars had dropped, and I'm having to give orange juice or applesauce or something to counteract that. So she definitely was out there promoting room service for us in this process to help manage the insulin. These are some stop signs, the samples that we actually put on trays to help the tray passing staff. I recently heard of a facility where they've actually trained their tray passers that to take the blood sugar and they write it down for nursing, so they're not having to track down nursing, and they went through a lean process to do that. So that's something that's out there that I know of this one facility I learned about a couple weeks ago that's doing that, and I think that's something that would be interesting that we need to get more information about. Staffing is very appropriate, important part of room service, having the right number of staff to deliver our meals timely, and not having too much staff, being able to staff to our peaks and valleys. When we look at a facility that's getting ready to do room service, if nursing is still doing meal delivery, we will have to add staff to the food service department. And room service does not increase your staff. A lot of staff gets repurposed into other types of jobs that maybe they're no longer exist in the current environment. There's not a diet office, but we have a call center. We now need staff up on the floors delivering trays. So we create some new positions and repurpose staff, and we're always usually having to add staff. It's very rare that we have a facility that has enough staff to do room service previously. Our ratios depend on how far it is from the kitchen to the nursing unit, the number of patients we have that aren't participating in room service. How do I get selections from rehab because they're not calling me, or I have a behavioral unit that I'm doing a non-select menu for. Staff need to adapt to the technology, and that happens at different rates. So your learning curve, there may be a point in time in your call center um, where we're using software that we have to staff more people because they aren't quick enough with the technology, so we may have a longer learning curve there and need more staff. Who's taking and recording the intake? So food nutrition is picking up the tray and recording that versus nursing coming in and getting the tray. We need the right staff for the job. We have cooks today, but they're cooking in bulk. They're not cooking to order. Our pace of our meal periods is different on a room service line versus a tray line. We have hour and a half where it's really busy, and then we slow down. Our meal period may be longer. You currently might be doing a half-hour tray line, and now my meal period is stretched out to an hour because the patients are choosing when they want to eat. Our goal is 2 to 3 trays per minute on the room service line. We need to hire for the right intent. We're hiring customer service people. We're hiring in a call center that's a little bit different skill set than maybe we've had before. Cooks are cooking to order. Whenever you have to hire into these positions, I've seen numerous times where staff are deciding they don't want to maybe make a change. They're close to retirement, past retirement age, and decide that they're going to retire versus go through one more change in our department. The other thing we see is we need to hire extra staff because there may be some people who do not adapt and decide to leave after we've started room service. I think I have a delay again on my...
I got it, Della.
Okay. So staff training. Our current staff is very knowledgeable in what they're doing, but we're changing everybody's job in the kitchen when we go to room service. So we need to train for cooking to order. We need to train in software if we're using tray tracking hardware at point of delivery. Customer service training, we're interacting with patients and nursing maybe more than we ever have before. We have different scenarios and situations we need to prepare our staff for. We have the scripting. The starter and expediter positions on the line are critical to determining our speed and accuracy. The starter needs to put a certain pace to put those trays. The expediter needs to make sure the trays are accurate and we're still hitting that 2 to 3 trays per minute. There's going to be changes in the work department. Staff are used to, doing tray line, then all going on break together. In room service, that doesn't happen. We always have to have that line open, so we're staggering breaks. And these social times that we've had in our department before no longer exist. So the next slide.
Sure.
Staff, I don't know why it's working sometimes and not. Staff appearance is real important. I know in today's world we do have hospitals where their staff looks sharp and has that hospitality look. That's the look we want to convey. We want to look different from the nurse or the physician who are wearing scrubs or the lab person. Staff often resist a change in uniform, so it really needs to be, as the managers, we're deciding what that looks like. We want that professional look, but we have had clients who instead of the white shirt, let their staff choose what color the department shirt's going to be, but they still put them in have the black apron and that professional hospitality look. We've seen staff really complain about making this uniform change, but on go live day when they're up on the floor, they're looking sharp. They get respect from nursing. They have people complimenting me on how good they look. They do a 180 degree in their attitude on that first day, just because they have pride in their job now, and part of that being able to have pride in not only what I'm serving to my patient, but in how I look. Room service is a multidisciplinary process. So the next slide. And it involves the whole facility, not just food service. And when it's driven by only food service,
Do you want it back?
I want it back, yep.
Yeah. Okay.
One more. I think one more, yep.
Webinar, I have to apologize. GoToWebinar is having some challenges. I just spoke to supervisor there, so they are having some challenges. So I apologize to everyone on the line. You were very lucky because people got blocked out of it coming into it, so they're having a challenge there. So again, any questions, type them in. We'll get to it. And Della, all yours. Go ahead.
Okay, thank you. So room service has to be a facility initiative, not just food services. Food services trying to drive this change throughout the organization, it becomes very difficult. The change we're making in how we deliver meals to our patients affects nursing, it affects pharmacy, it affects the therapist, physical therapy, occupational therapy. We're looking to environmental services often to assist with getting the menus in the room when they turn the room and clean the room. We don't pull these people in at the beginning, and they're not all behind this change in delivery of care and improving the patient care within the organization. It makes the success of the program a lot more difficult to achieve. And usually, once if we've gotten through the change and implemented nursing therapy, they see their patients are happier, satisfaction's better, and everyone's on board with that, and they don't want room service to go away. We need the proper equipment to do our job. A well-designed room service line helps with that. We need the right size delivery cart. We need induction chargers, a starter station that allows us to have all of our condiments in an organized and condensed space. We don't need tons of condiments. We just need to be able to get through each meal, but typically we have the starter station with 30 or 40 items on them. We need a microwave and convection oven, chrome griddles, combi ovens are all part of that appropriate equipment. The appearance of our tray, do we have beat-up trays? So we need new trays that look more like a hotel type of an environment is also a part of having the appropriate equipment. On the next slide, I have a picture of a delivery cart. And the carts that we recommend hold between 8 to 10 trays. We want a cart to leave the line every 10 minutes. So regardless of from the first time the first tray goes in. So we're not holding trays for long periods of time, so we don't need really big carts. This is actually a lakeside cart that a client had a 3M wrap put on, and I thought it looked very nice. It distinguished it. It said room service as it was going, down the line. People could tell it was a food cart versus some other type of cart. We do need large carts if we're feeding a rehab unit or a behavioral where everything's going up at the same time.
And Lakeside is a division, All You Serve is a division of Lakeside, so just, their sister companies, and what she was talking about can be done for any piece of equipment from All You Serve, everything from the meal delivery carts to hydration carts to things like hospitality carts for this kind of room service mode.
So our carts are chosen based on, the number of trays, how far our distances, being able to get food within 45 minutes, and we want to keep and maintain our food temperatures. Tray appearance. We want a hospitality look. We want it to look like it's being served in a hotel. Our current patient trays may have diet kits. We may have foam. Marsha, can you advance?
Sure.
I think I keep trying to advance, and all of a sudden we go 10 ahead. So things may not have a place. We may be using the translucent souffle cups instead of black. The next slide shows a picture of potentially a traditional tray from a facility. And this is not the look that we want. If we go to the next slide, it shows us, well, we talked about we want clear lids, and this shows us what that 5-star room service tray can look like, and our staff dressed in a hospitality look. And it's very different appearance from what we have probably today in our organization. When we're taking our patient orders, we want a call center. We need software for taking our orders. We need phone software. It's called automated call distribution, or ACD software. We typically are staffing for 12 hours, 6:30 to 6:30, 7 to 7. We have patients and family members can call. It doesn't just need to be the patient. And we want a mechanism where an ambassador can visit those patients who are unable to call by using an iPad or a tablet to take that patient's order. So the next slide, some key points about our room service software. We want to be able to monitor our nutrients. The screens need to be laid out for efficient order taking. We need to have a ticket layout that's designed for it's easy for the cooks to read. You're going to need resources to build the menu and set up the software. IT is a component of this project also, because there potentially are interface changes, hardware and software that needs to be installed. We're looking at Wi-Fi capabilities, and we need their support with our project also.
So again, Della, these are key components of it. The IT, the look, the equipment are the key components. And when you spoke about those must-haves, those are the must-haves.
Correct.
Correct?
Correct. So there's a slide that shows us kind of the keys to the ticket layout, things to think about when we build our ticket. Um, you know, sometimes less is more. If I say, oh, let's put cold sandwiches in a prep area and hot sandwiches in a prep area, patients don't order from all of these different parts of our menu, so then we can have a ticket with a lot of blank space on it, and then the ticket gets long and we're wasting paper. So these are factors on this slide to consider when we're building our ticket. Do we want to see our carbohydrates? If I'm serving lettuce and tomato with a hot and cold sandwich, it needs to print on both of those types of printers. There may be messages that we need on our ticket. Room service software also usually has a component for tracking our trays, and this helps us know if we're getting them to the unit within 45 minutes, and if we're not, helps us drill down in our data. We can monitor our staff productivity. We had a client who actually used their tray tracking software to determine that some staff were not coming right back to the kitchen to get a cart to deliver trays, that they were taking extra breaks, and they were able to use the software to find that information. Some of the systems allow nursing to view tray status of their patients. The call center ambassadors can also do that. In order to use tray tracking, take orders at bedside, we need good Wi-Fi capability. That needs to be thoroughly tested. Within our facilities, we have public and private networks. We need to be on our private network because we have patient information. Phone system requirements, you know, it needs to allow our calls to queue, and we need reporting capabilities that tell us what our average call length is, what our wait times are. We can then base our schedule around that information so we're staffed for our peak and have enough people so our complaint isn't that I'm having to wait for my call. We also need a mechanism for contacting our hostesses and potentially our nursing staff, and some options that are out there within various facilities. Both there is very common, SpectraLink is common. Jabber is an application that can be put on a tablet, turn your tablet into a phone. So those are some different types of things to consider when looking for communication. There are lots of people who have gone out and done room service on their own. Partnering with an expert consultant such as Demystifying can help you navigate around the pitfalls, help think of all of these little details and make sure that we've planned everything accordingly. They help determine staffing, line design. Architects, kitchen design consultants may know about kitchen design, but don't understand how room service operates and may not design your kitchen and your table to meet the needs that you have within the hospital. If we don't have a good design, it costs us in more labor and slower meal delivery times.
Della, a question I got. I have a few questions, so
Okay.
I'm going to pause you. I'm going to pause you right now so I can get some of those questions. Someone said you mentioned that anyone can do room service. Why do you feel that, in maybe a sentence or two, why do you feel that anyone can do it?
It's a different way of feeding your patient, and anyone can do it. I'm going to say if they're given
Any size hospital, any size facility, that's where I'm coming from.
Yep, any size hospital. We've personally done it in a 1,200-bed facility with 3 lines, and we're hitting the 45-minute delivery windows. It has to be designed correctly, and you have to be able to have the right amount of staffing to do that. You know, in a 10-bed hospital, if we're going in, we're doing a new implementation here that we're just starting in a 10-bed hospital. We may just be rearranging some of their equipment and training their staff, and we don't have the expense related to what we would in a large hospital because we don't need as much infrastructure. Their grill might be the same grill that they're sharing with the retail area. So there are ways that you can provide this regardless of your size of facility.
So it's about option and it's about focus. So someone said, is this service the point of service? Do you know what that means? Is this service, this room service, the same as point of service?
I'm not sure. That was the question. Point of service means to me.
I'm going to ask Ruth if you're going to give clarification on that. If you can send me a little bit more clarification so we can you know, elaborate on that question. So we'll pause that question. The other question is, if I'm on room service, do I have to order every day, every meal?
No, so we will allow a patient to skip a meal, and if a patient skips 2 meals, then we have a dietitian or somebody from the department go and visit that patient, find out why they weren't ordering, because we want to make sure, and identify any situation that there may be where we might need supplementation. We do often have patients in oncology units where nursing has told us it may be, end of life and they're on comfort care. Then we don't force them to eat if they're choosing not to eat. We're not even calling to find out. We typically will run what we call a missed meal report, and all the software systems have them. To identify patients who haven't ordered, we will give a courtesy call. See, you didn't order breakfast. Would you like to order? Sometimes the patient didn't know there was room service and they needed to call. They don't have a menu. So we want to make sure we're catching everybody, but we don't make everybody eat every meal.
Okay, and then one of the other questions is, for 100-bed facility, what is the average room service FTEs?
That really is going to depend on your facility. I can't give an average number. Do you have access to elevators? What's the distance from the kitchen to the nursing unit? There's lots of things that come into play. One thing that DM&A does is we do a room service assessment at a minimal cost. We can come to your organization and provide you the information, and the sample ROI that we have up on screen shows that, and we would then, based on seeing your institution, give you a number of FTEs that you would need to do room service.
Okay, we have a few more questions, but I'll pause to go back to the sample ROI so we can, and then I'll come back to the few questions that we still have some more.
Okay, so with this sample ROI, part of what we do in this assessment is we identify projected food savings based on reduction of late trays. We're not cooking to a line, holding food in a steam table, throwing it away. We're cooking to order. And that reduction in our food and supply costs helps offset our capital equipment and our FTE add. And in this example is that you see that we're making a positive contribution by year 4. We have actually paid off the initial investment, and our savings are offsetting our FTE add at that point. And this is a fairly typical, but we also have institutions where we don't have an ROI. We go out to year 10 and there's not a return on investment because of the amount of labor that's had to be added, or there were huge construction costs. But it's still, we are still reducing food and supply costs. We've offset part of that expense. We just don't necessarily always pay it off. And that's why we say when you embark on room service, it's about improving the quality of our service to our patients. It's not a cost-saving measure.
Thank you.
Talk a little bit about what a first day can be. Breakfast is done around 8:30. We're getting lunch done around 1:30, dinner by 6:30. We're getting the meals up on time. We have raving fans. Staff gets their breaks. There are people, and I've heard stories out there who, especially those who have tried to do this on their own, where this hasn't happened, and at the end of the day, they're wondering, why did they embark on a room service? This is not going to work. One of the things that DM&A does when we assist you with your project is we bring in 5 or 6 people to work along with your staff and assist. So if things do happen, we've done go-lives where there was a power outage, we've had a server go down, we're there to step in and help you and continue to help get this room service off the ground. It takes a lot of planning, training of your staff, hiring the right staff. We want to staff up on day 1. We want to have the software vendor on site. We have a team on site to help you when you embark on room service. It's a full-time job. You already have a full-time job, so working with somebody to help you build this helps you be more successful, and we can do that. Typical implementations are 9 months to a year from the start in an average sized hospital, depending on how much construction there has to be um, go into play for that.
Okay. So a few other questions. How do you recommend showing pricing for guest trays if you were doing guest trays for room service?
So really pricing, some people price it closer to their cafe, others want to provide it as a service. Definitely need to look at, we see prices probably are average between $7 to $10 per tray. Taking your food cost, averaging in a convenience factor. Yes, your
So
visitor can come to the cafeteria.
how would you communicate that? How do you communicate that to your guest, your patient guest? So
It's
is there a way to
printed.
do that?
It's printed on. If you're offering guest trays, it's printed on the room service menu. That's
Correct.
how they can call and order.
And does the ticket print off by location? We have a big hospital and it would take one staff a long time to walk from one side of the hospital to the other. So how would you set up? What would you recommend? Just, I mean, obviously not knowing the facility, but what would you recommend? Location, unit, how do you recommend people do
So
their?
we typically, right. So we divide your hospital up into what we call zones, and we have a cart for each zone. In some large facilities, a zone might be a floor, it might be one nursing unit. So we have divided up into zones, and so as the trays are coming off the line, I have a cart for zone 1, 2, 3, 4, 5. Your ticket says this tray goes to zone 1. I put it in the zone 1 cart. So when the ambassador or hostess leaves with that cart, all the trays in that cart are in one general area.
Okay. So another question is, the question was about how do I convince administration or my CEO that whether I'm long-term care, healthcare rehab, hospital rehab, to move forward with this? Are there any top 3 things that I can say to them? For example, Della, I'm thinking, you could do service recovery quicker, and you can do, patient or resident satisfaction. What would you say in all your experiences of doing it? What was the win-win?
The win-win is around patient satisfaction, and we can demonstrate a reduction in food costs because there's less waste. If any of us have looked at how much food gets thrown away, so when a patient orders what they want, they're eating what they want. And I think those are the 2 big, and there's, there's documentation, there's articles published on what people have saved in food costs. And in addition to, if patients are complaining, you have a lot of complaints around food, room service giving the patients the option to choose what they want to eat when they want it, then takes those types of complaints away.
Great. And I would think it's more sustainable in the sense that there's less food waste and less scraping of the trays. And I would also, in my years of experience, I think room service gives people choice. Everything is about option today, and it gives people the choice. It's not dictated. They get some control on what they get to choose based within their diet, allergies, etc. But I think that's choice, and everyone wants something to control. The other thing is, thank you, Della. Thank you, thank you, thank you. We're coming to the close of it, but I did checking questions. The other question, one final question is, what about high temperature cooking, turbo chef types of equipment instead of combi ovens, some of the ventless equipment? Could that be used in a room service back of the house situation?
Yes, we're actually putting rapid cook turbo type devices on our room service lines, and I think we do have some facilities who weren't able to put into hood, and so when we did constructed the room service line, provided equipment suggestions, that was all taken into consideration, and the right type of equipment was put in the facility.
Excellent, excellent. And I see there's some questions about the wrapping and the carts. All You Serve and or Lakeside can help you with that. They will help you with the carts, and they do the wrapping on it so that it's food safe and sanitary. And for cleanliness ability, it's really sealed in. So if you have any questions, you can send me an email or you can call Kevin Vegan to help you with those, and we can help you more with that. Some housekeeping tips. The certificate of participation will be on our website, All You Serve's website, by Monday. The PowerPoint and the recording will be available as well by Monday, and you'll be able to get that. I have to apologize again. GoToWebinar had some challenges, and I would say there's a portion of you that weren't able to get on the webinar. A lot of you were, and so we will have it recorded for the people that couldn't get on. But any other questions, anything, Della's contact information is on this as well. Hope we gave you the ability to demystify that room service is just an option, and it's easier than you think to implement a program, and obviously having experts like DM&A help you coordinate and get the ROI, or any of the consultants that are out there, make it easier and make the navigation through the room service forest a lot quicker and more successful. Della, any final words?
No, thank everyone for their time today, and again, also reiterate, apologize for some of our technical difficulties. From doing room service, the thing that I love the most about an implementation is that first day and all the compliments and the happy patients that we have, and really seeing that we are making a difference in our patients' experience. And that's why I do what I do, is to improve that patient experience.
Well, thank you. And one final note to remember is HCAP scores definitely show improvement factually, and thus can increase your Medicare reimbursement as well. So that is certainly a selling point to your administration. So people are looking for to the bottom line, in addition to the waste and the food costs. Sure, if you get more Medicare reimbursement because your HCAP scores are higher, it's certainly a reason to move towards room service and give people the choice. So again, Della, thank you so much. Hope you enjoyed our participants who attended, enjoyed our webinar today, and thank you for joining us. Thank you.